Hello everyone and welcome to this audio podcast. This audio podcast as part of the Erythropoiesis edition. This audio podcast as part of a Hurricane Plexar. This audio podcast as part of a Labonix Vendip. This audio podcast as part of a Storm Robotics production. This audio podcast will go into some of the this audio podcast will look to will look to provide some basis for prospective investigations as part of this audio podcast. As part of this audio podcast series, but also as part of research in around pediatrics, pediatrics or pediatric nephrology, but also in around laboratory medicine and pathology. And so uh, and so the and so the following should be done in order to gain a better understanding of drug-induced nephrotoxicity, drug-induced nephrotoxicity or immunosuppression in pediatric renal recipients. So the first looking at the first is around TDM or therapeutic drug monitoring. So therapeutic drug monitoring has been shown to be helpful in the following basis. So recipients with hepatic impairment, pediatric recipients. Recipients receiving concurrent doses of drugs are known to interact either by altering biotransformation or the extent of absorption. So, for example, sirolimus or SRO has been identified with or it has been identified with the co-administration of for example, diltiazem, ketoconazole, and CSL. For example, soft gelatin capsules, sort of retrospectively, whilst also decreases have been identified, decreases of TDM, or the efficacy of SRL has decreased with the use of rifampin, and at the same time, recipients in whom where a CSA dose has been markedly reduced or discontinued, and recipients who are at high risk of acute rejection, and recipients who may not adhere or comply with dosages or regimens. Specimens for therapeutic drug monitoring should be drawn at the at the trough time being 24 hours post dose or just before the next dose. Inappropriate timing of specimen drawn relative to dosing is in general a major contributor to the failure of TDM therapeutic drug monitoring to contribute in around generally, and future investigations should delve into looking at TDM, and how it could be more how it can be more how it can be more how it can be bettered. So another basis is in around pharmacokinetics and pharmacodynamics of immunosuppression. Sandoz retrospectively produced neural a sort of a a sort of a better absorbed formulation of CSA or cyclosporine, thus improve the pharmacokinetics. Though the toxic effects, initially were or had not been evident. However, more work had been required on the mechanism of action of the therapy, and so it has been of intrigue to identify whether other nephrotoxic drugs could be researched better. So maybe they could potentially they could work using different pathways interactions for therapy, thus reducing nephrotoxicity. The problem may be at the same time that at the same time where the desired therapeutic efficacy effect may not be achieved. This includes receptor-mediated studies based on drug interactions and related or regarding aspects. Another aspect is in around efficacy, potency, and sort of the therapeutic dosing, but where therapeutic dosing is a basis in around and the area what's been referred to in pharmacokinetics as AUC, or area under curve. So with the above in mind, immunosuppression therapies need more research in around efficacy and potency. So for example, so one question is, how can you reduce nephrotoxicity or toxicity, but still have a drug that maintains efficacy, potency, and stays in the therapeutic range? So more pharmacological investigations are required, and align with this, where are required in line with the Major Histocompatibility Complex (MHC) and in around the Human Leukocyte Antigen (HLA), in around HLA, and the recipients and where recipient is still required to take, and where recipients are still required to take immunosuppression, or the pharmacotherapies. So also in around sort of blood trough levels and blood whole concentration. So research has been documented that all laboratories that carry the appropriate analyses for levels of toxicity show some degree of disagreement based on toxic doses. Thus, it is vital that research on a toxic dose is established so that a patient or recipient has a dose that affects the immune response or causes toxicity to produce, then that dose should be confirmed as toxic. Here, better investigation need to be carried out, carried based on trough and whole blood concentration, and thus better immunoassay and analytical techniques, or at least data produced that everyone that specialists can have consensus or agree on. And in around the MHC, and where MHC in synchronicity with HLA, immunosuppression therapy in pediatrics is difficult to understand completely, just as much in adult recipients. More research is required. More research is required based on the MHC, and antigen presenting cells. This requires collaboration this requires collaborations between immunologists and nephrologists. This will hopefully also determine better allograft prognoses. So in around this at the same time, a little bit around a basis of other regimens, if you like. There are many therapies on the market or have been on the market now, And what would be intriguing is if therapies could be produced as, for example, as topical solutions for pediatric recipients. Um, uh, as topical solutions for pediatric recipients. Thus, they rub on the medication on the transplanted area, and in this case the kidney or the abdomen to achieve suppression of donated organ of donated organ or of in around the solid organ transplant. This may not work for other donated organs because of practicality. While no chemical or drug can be certified as completely safe, free of risk, since every chemical is toxic at some level, it is usually possible to determine the risk associated with exposure to the chemical under specified conditions if the appropriate tests are executed. The major kinds of information required from the preclinical studies are: one, acute toxicity effects of large single doses up to lethal level; two, subacute and chronic toxicity effects of multiple doses. Multiple doses, which are especially essential if the drug is intended for chronic use in humans. Where immunosuppression therapy is concerned, this is the case. Effects of At the same time, effects on reproductive functions, including tetragenicity, carcinogenicity, mutagenicity, and investigated toxicology. In addition, several quantitative estimates are applicable. These include, for example, the sort of no effect dose, the maximum dose at which a specified toxic effect is not observed, and the minimum lethal dose. The smallest dose values established to terminate any cell, and if necessary, the median lethal dose. The median lethal dose in pharmacokinetics is referred to as the LD50 or 50. It is vital to recognize the limitations of preclinical investigations, and these observe the following. So, number one, toxicity testing. Toxicity testing is time-consuming and can be expensive. Unfortunately. Number two, large numbers of animals are used to obtain preclinical data. Number three, extrapolation of toxicity data from animals to humans is not completely reliable. And number four, for statistical reasons, rare adverse effects are unlikely to be detected, just as in clinical trials. So that draws this audio podcast to a close. This audio podcast was a sort of an overview of in around some prospective investigations that could take place in around looking at varying sort of parameters and specifics in around investigation around immunosuppression to enhance sort of the safety aspects in around pediatric recipients, sort of post transplantation, and the subsequent audio podcast will go into some of the conclusion aspects of this works, and this as part of this audio podcast series. So this has been an audio podcast as part of the Erythropoiesis edition, as part of a Hurricane Plexar. This audio podcast as part of a Labonix Vendip. This audio podcast as part of a storm Labonix production. Thank you.